Okay, the next topic that I'm going to discuss is going to be heart failure. And with heart failure, really, the most important thing to remember is that a failing heart is a heart that cannot meet the body's oxygen demands, as in it can't meet the metabolic needs of the body. Say if one is doing some exercise, or even if one is sitting down, if there is severe heart failure. And so that is the definition really of a heart failure. It is a heart that cannot meet the body's demands. Before I actually dive into heart failure in a great deal, I just want to review that in the last section, in the last lecture, I made a mistake when I was talking about the troponins. I wanted to say tropomyosin, but I say troponin M. So I really need to correct that, because we only have troponin C, troponin I, and troponin T. And another mistake which I noticed was always when I was talking about the sodium potassium ATPase, or indeed the sodium calcium exchanger. And the other, and I also forgot to actually talk about that when the cell depolarizes, it actually reaches a threshold, and reaching a threshold is the time that it means that the cell is ready to do the job that it's meant to do. So anyway, those are the 3 points that I wanted to clarify now, which I noticed. So then today I'm just going to talk about heart failure. And the definition of a heart failure is a heart that cannot the metabolic demands. Now, heart failure can be, there is a classification which uses something called the New York Heart Association scoring system, and this system actually scores heart failure into four grades. For example, like grade 1 is someone with no symptoms at all. So we'll just say no symptoms. They're fairly, they're doing well. There is nothing wrong with them. And then grade 2 is a person who has moderate symptoms on a high exertion, say exertion, such as perhaps if they are running up the stairs. And then grade 3 again is still moderate symptoms, however is on less exertion to that, say just with minimal exertion. So this is grade 3. And then grade 4 are people who are really unwell. They have symptoms at rest. And so this is the New York grading, the New York Heart Association grading system. Apparently, when I was reading about heart failure this week, I've noticed that they say that this system is not the best way to grade heart failure, because apparently patients can perhaps present, they can either go up and down on the system. So really it's not a very good record of monitoring someone and ensuring that the treatment is working. So instead, there is another staging system that's used, which grades heart failure based on staging A to D. And stage A is someone who has all the factors that cause heart failure, things like hypertension, things like coronary artery disease, However, they have no symptoms at all. So these are the people who have the risk factors, shall we say. Like they have all the risk factors, but they have no symptoms. And then grade B are the people who already have risk factors as well, and they are showing some minimal symptoms. They have some symptoms of they have developed okay, these people have risk factors and no symptoms. These people have risk factors and they have developed diseases arising from risk factors, but they haven't really shown symptoms of a failing heart. They have the symptoms of primary disease. So these are people who have the symptoms of their primary disease, because I think it's important to remember that heart failure really is more like anemia. It's not really a primary disease. It is a manifestation, or it is really sort of like an indication of another disease, of another underlying cause that is actually causing the heart to fail. So we can think of it really as a secondary disease. So people in stage B actually have symptoms of the primary disease, things like hypertension, coronary artery disease, and then people in stage C have symptoms. They're already unwell. These have risk factor disease and symptoms of that. So these people have actually developed heart failure, and they have symptoms of heart failure, because what I mean by saying they've actually developed heart failure is that while the first patients have just risk factors and the second group of patients have the disease from those risk factors, these people's heart are starting to fail and they are showing symptoms of heart failure. And then stage D patients are people who are really, really unwell. They have heart failure with symptoms, and they have been treated medically, so medical therapies. However, medical therapies are not working for them. So although they are on maximal, they are on maximum drugs or medical therapies that we can give, they still show symptoms of heart failure. So it means that they now need the next stage of management, which means that they definitely require surgical intervention of some sort, such as perhaps such as a heart transplant, perhaps say if it was a valvular underlying pathology, perhaps a replacement of a valve, or perhaps just repair of that valve. So these people in stage D have already been treated medically, and medical treatment has failed. So the next stage is to look into surgical therapies, including heart transplant. So this is how we grade heart failure. And now we have to look at what are the symptoms of heart failure quickly. The symptoms of heart failure can be divided into right heart failure and left heart failure. So right heart failure, really, if we were to go back to how the heart works as a pump, we will remember that on the right we have the right atrium, mitral valve, tricuspid valve, and right ventricle. And the right atrium receives its blood from the vena cava, superior and inferior. So the symptoms of right heart failure really are the back pressure going back to the system, the blood going back to the system from where it's come from. So the things that we will see in people with right-sided heart failure will include peripheral edema, which we can call systemic edema, but we'll just call it peripheral edema. We'll also see things like ascites in the liver and hepatomegaly. And hepatomegaly in these people will present as right-sided discomfort. So we're mainly focused on the things which which are contributory to the right atrium. Again, we'll also see an increased jugular, venous pressure and distension. Shall we say distension really, because we'll see it throbbing. So these are the main signs and symptoms of right-sided heart failure. Then if we're to look at left-sided heart failure, again, it's important to look at what the left side of the pump actually does. It receives its blood from the lungs, oxygenated blood from the lungs, into the left atrium through the mitral valve and into the right ventricle, which is the actual pump into the body. So when this pump is failing, there are two things which are happening. The body will not receive its oxygen demand. So these patients will have dyspnea. They will feel fatigued because obviously they are not receiving any oxygenated blood. And if blood is going back, if there is a backward flow into the lungs, they will have pulmonary disorders such as pulmonary congestion, and pulmonary congestion can also be orthopnea, where a patient cannot lie flat, because obviously when they lie flat, then blood redistributes and more pressure is put on the heart, causing it to then force blood back into the lungs. They will also have things like paroxysmal nocturnal dyspnea, which again is waking up in the middle of the night, unable to breathe, feeling short of breath. Again, it's also caused by the back pressure into the lungs. They will also eventually have cor pulmonale, which again is a manifestation of that backward flow into the lungs and causing things like pulmonary congestion, which happen together with the failing heart. So they will also produce frothy pink sputum, which again is caused by the bursting of the vessels in the lungs as the pressure increases in the lungs. So these are the most important symptoms and signs and symptoms of heart failure, and I've grouped them based on the right heart failure and left heart failure. So now I'm just going to very quickly talk about the physiology of heart failure. And I think for me, when I'm learning this, the most important thing that I say to myself is that obviously the heart is a pump which does two things. It has to feel and that feeling of the heart is obviously the diastole phase of the heart. And during diastole, the heart has to relax. And as it relaxes, it has to receive blood. And in receiving that blood, obviously, it will then expand a bit, as in shall we say dilate, because enlarge sounds like I'm talking about hypertrophy. So it will dilate a bit to sort of, myocytes will expand to allow to accommodate blood that's coming in. So this is the diastolic phase of the heart. And then we then need the pumping phase of the heart, which is the systolic phase. And during systole, the heart is in action. It's constricting forcefully to then push blood out. Shall we say forward ejection? Yeah, forward ejection of all the blood, of the blood that was received during diastole. And then another thing to remember is the Frank-Starling mechanism. So with the Frank-Starling, if we were to remember that, all that it explains is that if you increase the volume of blood in a ventricle, you then allow that ventricle to dilate, and it's like an elastic. It will stretch the ventricle, the myocytes, and as the myocytes stretch and fill with volume, the force of contraction will increase and blood will be ejected out of the ventricle more forcefully. So then we're looking at, if you increase volume, you increase stretching of the ventricle, and you increase force of contraction, which means we increase cardiac output, and if we were to remember, cardiac output is equals to stroke volume multiplied by the heart rate. So so these are the three things that we really have to remember when we're talking about a failing heart, because all the pathology and all the physiology is based on what happens in diastole, what happens in systole, what is the Frank-Starling mechanism doing in order to compensate for what has failed to happen. For example, when we talk about heart failure, we can talk about it as saying, we have a heart failure with a reduced ejection fraction, Again, we're not talking about a heart failure with reduced ejection fraction. we're talking about mechanisms that are happening in systole. I'm obviously simplifying this so that it actually makes sense and it's easy to learn the physiology. So we're talking about a heart failure with reduced ejection fraction. And if we're to remember what matters in ejection is the forward ejection of the blood. So we're talking about a systolic heart failure. And the things which will cause systolic heart failure are things which stops the heart from, I need space, are things which stops the heart from actually pushing the blood out. So the things which will stop the heart from pushing the blood out are things which reduce myocytes. Myocardium. It doesn't matter. Cardiomyocyte. I don't know why I just write myocyte. Myocardium. That's right. Which reduce myocardial stretch, and things which will actually stop the cardiac cells from stretching are things which include infarction, ischemia, or perhaps even stiffness caused by hypertrophy. Oh, I can't spell. Forgive my spelling if it's wrong. So then these are things which will stop the heart from contracting by a pathology that's lying in the actual cardiac cells. And then things which will actually also stop blood from being pushed forward are perhaps a failing valve, such as aortic stenosis, which means that it cannot open properly, therefore blood cannot leave, no matter how forceful it is being pushed against something that's closed. And also things that where am I up to? If the myocyte again has no energy, and say if it's too dilated, which is in hypertrophy, then it can't really squeeze no matter how much force. Say if you're giving enough, the same amount of force, and you're just squeezing a big barrel. Okay, say if you had a barrel that had 100 mils inside, okay, that had 5 liters inside, and this barrel is normally squeezed by 100%, well, let's just say 10 joules of energy, right? And when you do that, you get all that cardiac output, 100% cardiac output to meet your body needs. Say if this barrel expanded and became this big, and that 5 liters is just sitting at the bottom there, if you were to apply that same amount of force, nothing will happen. You probably just get a drop, something like 20%. Obviously, I'm just making out these numbers just to demonstrate a point. So really, if the heart is dilated, like if the chamber has become big, but the muscle itself has remained the same, as in if you have concentric remodeling, then obviously the forward ejection will not happen as well. And then things which well, that as well actually affects the diastolic heart failure as well. So in terms of going back to the diastolic heart failure as well, it's usually again caused by stiffness of the heart, stiffness of the walls, especially things like fibrosis. And again, this dilatation of the atria in particular, because the atria is the one that has to receive all the blood from the body and push it into the ventricle for it to be pumped throughout. So we have now talked about what heart failure is and the two types of heart failure, where the systolic heart failure is heart failure with reduced ejection fraction, which means that we cannot eject blood going forward. And then we also have heart failure, but with preserved ejection fraction, and that is really diastolic heart failure. And again, this is based on the actual ventricles, the actual walls of the heart not being able to relax and collect the blood that it needs to collect. And also we can have eccentric remodeling of the walls, whereby we will get a chamber that becomes ever so dilated, and without meeting eccentric, yes, the chamber will be dilated without meeting without the walls being dilated, so there's that mismatch. Or we can have a concentric, where the walls, the muscle fibers themselves actually enlarge and become bigger, but then eventually will lead to things like hypertrophy and fibrosis. So although it sounds like it's a good thing when it happens, it can then cause pathology to occur. So now we'll move on to, we've talked about briefly touched on the physiology and explained it in simple terms. We then need to actually talk about, I actually forgot that. So now the next phase of heart failure is the compensatory mechanisms that the body These are natural mechanisms that the body itself activates in order to overcome the processes of a failing heart. For example, when the body is not receiving enough perfusion, particularly the kidneys, if they are underperfused, will sense that reduced perfusion and sense it as there's something wrong here, and activate the renal angiotensin, renin, I cannot believe I said it, renin angiotensin aldosterone system, and this system, the main point of this system really is to rescue a failing heart and to increase cardiac output and to increase blood volume. So the kidneys will secrete renin, and renin and renin will convert. Renin is an enzyme. So the kidneys, as number one, will secrete renin, and then the liver will secrete angiotensinogen. In fact, angiotensinogen is always in the blood, it's always in the body, it's flowing around. When it's not needed, it's not converted, it's inactive. However, in cases of underperfused kidneys, the kidneys will secrete renin, and the function of renin is to activate angiotensin. So renin will come in and activate angiotensin into activate angiotensinogen into angiotensin 1. Angiotensin 1 is then converted into angiotensin 2 by the angiotensin converting enzyme, which we naturally call ACE. Angiotensin 2 does two things. It binds onto the A receptors and causes vasoconstriction. And vasoconstriction obviously increases total peripheral resistance. And when we increase total peripheral resistance, we're increasing the pressure in the peripheral, and increasing the pressure in the peripheral system means that blood is returned into the heart much quicker, and a large volume of blood is returned into the heart. It just means that, because the system thinks that there is reduced blood in the body, so it will reduce the diameter of all the vessels, and that reduction of diameter of all the vessels allows the system to work a bit more efficiently. Angiotensin 2 also stimulates the production of aldosterone. And aldosterone really works back in the kidney by increasing salt and water retention. And obviously in increasing salt and water retention, we're increasing the volume of the blood. So this system does two things. It will increase peripheral resistance via vasoconstriction, and it will also increase the volume of the blood via retention of salt and water. So then another system that the body will do to compensate for a failing heart will be to secrete antidiuretic hormone from the pituitary. Again, this works similarly to aldosterone to increase blood volume. The body will also activate, the body will also activate the beta adrenergic system, and the beta adrenergic system is is part of the sympathetic nervous system, and all it does is it increases the inotropic